happy to contribute with the part on treatments. So actually in the program book, I'm still a member of the University Medical Center in Utrecht, but since 4 weeks now, I've moved to the Northern University Medical Center of the Netherlands in Groningen, which has fresh sea air and a great research climate. So I'm very happy with the change. However, my studies are continuing the way they've done before. And as many people have shown before, we had our wake-up call in the field of schizophrenia with the 2014 Nature paper by Ripke et al., who showed this great big peak on the short arm of chromosome 6. Now, we knew already that there was something going on in the immune system. Actually, it was Mortley, more than a century ago, who pointed out to that association. But this was really what made it quite clear that this topic is of quite high importance. And then 2 years later, in 2016, Segar proposed a model because he found several genes related to the complement system, especially complement factor 4, to be more often present in schizophrenia, which could lead to a more, let's say, trigger-happy immune system. And I much like the metaphor that Jehuda used this morning of the racing car instead of the Lada. So it could suggest that the genetic makeup of patients with schizophrenia are more towards the racing car model. So Hemmer already pointed out that the microglia has a very central role in patterning several organs, and specifically in this case, the brain. It has important functions in early brain patterning, but also in keeping organizations of nervous circuits during adulthood. And if this microglia cell is just a little bit too trigger happy, it might abandon its central functions and go over into more activated forms. So to see if this model is actually present in the brain of adult patients with schizophrenia, we did a research on literature using post-mortem samples of patients with schizophrenia. So we could include a total of 38 post-mortem studies assessing some type of immune factors in patients with schizophrenia. And we divided them into those looking at cellular components and those looking at molecular parameters. And then from the cellular markers, we divided them between microglia and macroglia. So let's look at the the molecular markers we divided into pro and anti-inflammatory. So let's look at the results from the cell fraction. We found an increase in microglia, which was quite significant. And we found that this increase was most pronounced in the temporal cortex, especially hippocampus, while the macroglia were not different between groups. Now, we don't know yet if this increased number of microglia has anything to do with activation, because we don't know what they're doing there. We just know that they're present. But therefore, the molecular markers come in handy, because we also found that the pro-inflammatory proteins, which are partly the products of these microglia cells, are also increased in the same areas in the same patients, making it quite likely that these increased numbers of microglia are also in a more activated state. While in the anti-inflammatory cytokines, we did not find any difference. So to sum up the research from post-mortem literature, a significant increase in microglia cells in the brains of schizophrenia patients, together with an increased pro-inflammatory molecular response. So this points towards increased activation of microglia in patients with schizophrenia. So could this be a new angle for treatment? Well, we can think of two important ways, and I actually think that the first point maybe even more important. This happens in a very early stage, probably already prenatally. And if we understand this better, and if we can think of ways to correct this trigger-happy microglia cell, we might actually be able to prevent the onset of psychiatric diseases like schizophrenia. Of course, we're not there yet, and we will need very mild interventions because, of course, the number needed to treat it will probably be high. A more easier goal will be to mitigate disease by compensating this high activation of microglia cells in adult patients. But of course, the effect from that type of interventions will be less spectacular, but that could be a goal that's within reach within the term of a few years. So let's look at this second goal, to mitigate disease in adult patients. So from theory to practice, let's presume that some of the microglia cells are in the primed or maybe even activated state instead of doing their important roles in regulating brain organization, which could use anti-inflammatory agents to decrease it and hopefully get these microglia cells back to their important work again. So we have first reviewed literature to see which studies have already investigated this. So there's, of course, a long list of drugs that have anti-inflammatory properties. And that's the nice thing about it, because this makes this angle of research so promising, because if we can do something about it, we have many opportunities to try that are actually new for patients with psychiatric disorders. So we've searched all these anti-inflammatory drugs, and some drugs that are not primarily anti-inflammatory but that also have anti-inflammatory properties. We actually found not so much. So I would say that there's quite a gap between what we know from molecular studies and what we actually have, like proof of the pudding. How does treatment affect these patients? But the little there is, I will summarize for you, which are, for example, 2 RCTs using aspirin, one from the hospital that I used to work. And together they have a mean weighted effect size of 0.3, which is significant. So it's not a huge effect, but of course it comes in very handy. And aspirin does have some side effects, but does also have some good side effects in preventing vascular disease. While our patients largely have metabolic syndrome, this might actually not be a bad thing. So aspirin appears to be a reasonably good candidate. There were quite some studies on Celecoxib, and unfortunately, the largest study on Celecoxib, which came out negative, has never been published. So we used the data from the abstract to include that study. And as you can see, the data are very diverse. And if you add them all up, nothing significantly comes out. So in contrast to aspirin, which is quite similar in several mechanisms of action, Celecoxib is not as promising at all. We also looked at Minocycline, and many people think that Minocycline would be the best option to reduce activity of the microglia cell. And indeed, it does have important impacts on microglia, but perhaps what it does is that it could actually more or less paralyze the microglia cell. So yes, it would make it less active, but it will not have it resume its proper role in organizing the CNS. And we have seen this also in patients with ALS and in patients with SLE, where minocycline can actually worsen the clinical pictures of neuropsychiatry. And also in patients with schizophrenia, there were very diverse reports, but in general, no significant finding for minocycline. Fatty acids. Fatty acids have several properties, but they also have some mild anti-inflammatory aspects, and the nice thing is that they easily pass the blood-brain barrier and could do some good there too. However, results do not look very promising, and it's a pity because this would be an ideal component that we could even give to very young children in order to prevent psychiatry on adult age, given it would have any effect, but it doesn't look that way right now. Another very mild component, also potentially usable for preventive purposes, is N-Acetylcysteine, which has many mechanisms of action, but also has some mild anti-inflammatory actions. Only one study coming from Australia, which looks good, but really in need of replication, because many positive studies come out from the same lab, and we really need an independent replication for this. Yet, it does not look bad as it is. Estrogens, of course, have many actions, and only few of them anti-inflammatory, but still they do have anti-inflammatory properties as well. And also they come out positive looking at symptoms of schizophrenia. As you can see, these studies vary highly, and there are two large outliers. So if I exclude these outliers, these two, then the situation looks a bit different here after exclusions, but still significant with a mean weighted effect size of 0.5, which is actually pretty large. I don't know if this is by its action on microglia cells. It may actually be by different modes of action. So to sum up what we have from the few RCTs that looked at anti-inflammatory components, aspirin is not that bad, as do NAC and estrogens. And from all these drugs, we're not that sure if the effects are actually immune-mediated. Unfortunately, fatty acids, Celecoxib, and Minocycline do not seem to be promising components. So you will probably agree with me that this definitely is the missing link. So we really need more information about, can we reduce symptoms, can we improve the clinical situation using anti-inflammatory drugs. For that purpose, we are currently including in 3 RCTs 2 are international studies, and 1 is running only in the Netherlands. And this is the team that is really having a hard time being coached by me, and I really want them to include, which is quite difficult, but they're not doing bad. So the first study that we're conducting is the simvastatin study. And in that study, we're treating patients with 40 milligrams of simvastatin, which is quite a high dose, for 1 year, which is quite a long time. It's a Dutch multi-center study. It has several outcome measures. The nice thing is that we're also measuring MRI, and we're trying also to measure microglia activity with PET. So we have quite a large panel of outcome measures. And as of today, we have 120 patients included. So we want to run this study for 1 more year and then unblind it and hope to include a sample of around 150 patients. So we're still blind, so I can't tell you anything about it, unfortunately. This study is running in first episode patients, and that's perhaps one of the reasons why it's running quite slow. Prednisolone study is a multinational study running in the Netherlands, Norway, and Belgium. And we're providing 40 milligrams of prednisolone for only 3 days, and then we're slowly tapering off the drugs during the next 6 weeks. So this is a short-term study, and we're mainly looking at clinical parameters. Unfortunately, we don't have PET and MRI in this study. And we have so far included 35 patients. This will not be a huge sample. We're aiming to include 70 patients because we do expect quite a large effect, as this is the most important anti-inflammatory drug we have, which virtually inhibits all components of the immune system. The third study is Raloxifen, which is a synthetic estrogen targeting the estrogen receptor in the brain. And the nice thing is that it's quite safe. You can actually give it to men, and actually we do give it to men and also to premenstrual women with schizophrenia. It's running in several Dutch centers and in the Netherlands. It's an intermediate duration, so we're treating patients for 4 months with a quite high dose of 120 milligram, which is double the dose used for osteoporosis osteoporosis. Outcome measures, quite similar, you probably know them already. As in all three studies, cognition is a very important aspect, as we do expect some benefits to be seen there. And we have so far included 39 studies. Now, this study has started a bit later than the other ones and will be including 1 year more. So the simvastatin and the prednisolone study will be finished end of next year, and I'm still blind for the data. I have seen from prednisolone data, the blinded data about how people go on during this 6-week course, because it's a high-risk study, so we have to do safety evaluations, and we do see that patients improve largely, but still, of course, we don't know which group is. So we really hope that this is the experimental condition and not the placebo condition, but we do see quite a lot of improvement. The Raloxifen study will take 1 year more, and that will be studied. It will be finished in 2019. So I don't have the answers to our claiming questions as of yet, but I do hope to have them within a short while. This is the Immune team that I'd like to thank, and I'd like to thank you for your attention here.